We are on day 3 now of our series, and I'm hoping today will bring many things together on a very practical way. Maybe because people don't attend every one of these, I'll just introduce myself again. My name is Lucinda Bateman. I'm a general internist who specialized in conditions of chronic fatigue and widespread pain for the last 10 years, and I've learned a lot. So we'll share some of those things with you. We're calling this session the effective use of evidence-based clinical diagnostic criteria and symptom management approaches to improve patient outcomes. But I think it will be satisfying because I'd like to talk a little bit about treatment strategies today that can be utilized by anyone, including primary care providers, for many of these disorders. I'm going to talk about 3 major sets of clinical diagnostic criteria and share with you why I think using this sort of a paradigm can really provide a framework for managing these complex multi-system illnesses. We'll talk about pain amplification disorders, orthostatic intolerance disorders, and then I'd like to introduce you to the ME/CFS 2015 clinical diagnostic criteria, which were published in 2015. So pain amplification disorders, we know there are many, but when the pain amplification is widespread, it meets the criteria for fibromyalgia. Now there's a lot of, let's just say, there's not consensus among all academics about whether to use the term fibromyalgia. And to me, it doesn't really matter. I'm going to use it in the context of this talk. And I'm going to use the term as defined by what are called the American College of Rheumatology 1990 criteria. And they're very simple, easy to remember. Fibromyalgia is defined by the condition being chronic, at least 3 months in duration, that it's characterized by widespread pain involving all 4 quadrants of the body and the spine, and it is also characterized by tenderness, which in this case, they used an evidence-based approach and determined that at least 11 of the 18 defined tender points should be positive. What I like about these criteria is they're very simple, actually. People got hung up on the tender point criteria, but this is chronic widespread pain and tenderness, and it tends to be globally affecting everything. It's all the different kinds of pain and sensory symptoms. And in this original paper, which is very good, they mentioned that fatigue, cognitive, and sleep disturbances were common in the patients, but they weren't required for the criteria. So if you could just picture 4 quadrants in the spine, and this is an actual pain diagram from a patient. There have been some iterations of these ACR criteria, and the most recent was in 2016. I myself prefer the 1990 because I think they're simple. I think that these newer criteria made an effort, though, to help point out that fatigue and sleep and cognitive complaints and some others were an important part of the presentation. So if you met, you could be diagnosed with fibromyalgia if you had at least 7 of the widespread pain areas and at least 5 added up in those symptom severity score, or you can have less pain, but it still had to be in 4 of 5 regions to be considered widespread, and then 9 or more of the symptom severity scores. But the point I want to make about widespread sensory amplification, and I'm going to use the term FM or fibromyalgia because it's easier, but this is a disorder that we should think of as something that can occur in a secondary way to many other conditions. It's not really a discrete disease. There probably are people with maybe what we call primary fibromyalgia, and I have a pretty good idea in my mind about what the risk factors are for that. But if you look at these 2 studies, the prevalence of fibromyalgia really depends on the background and the other conditions. So in internal medicine and rheumatology clinics, the prevalence of fibromyalgia is 15%. And in people who have IBS, 13% of them also meet criteria for fibromyalgia, which means the hyperalgesia is widespread, not just confined to the gut. In Behçet's syndrome, a rheumatologic condition, the prevalence of fibromyalgia is 80%. And I would also mention, I didn't look up more mental health codes, but bipolar disorder, as high as 21% meet fibromyalgia. That's why I say FM, FM criteria. I would say from my own clinical experience that the most common mental health disorder predisposing people to fibro are disorders of hypervigilance, like generalized anxiety, PTSD, and OCD. And it's kind of similar in bipolar disorder, but the stress physiology is activated, sleep is disturbed, and these are the things, this is kind of the environment in which hyperalgesia, widespread hyperalgesia can develop. And as we've talked about through our presentations, there are common manifestations in your whole body when you develop widespread sensory or pain amplification. And muscle and joint pain, migraine and headaches, weird paresthesias, restless legs, irritable bowel, pelvic symptoms of irritable bladder, interstitial cystitis, dysmenorrhea. And it's not just pain that gets amplified, it's all sensory signaling seems to become amplified in many patients. So they are sensitive to light and noise and odors and chemicals, similar to the things that Dr. Yeoman talked about in patients with the other comorbid conditions, drilling down to the underlying pathophysiology yesterday. In addition, Sicca syndrome, and then these adrenergic overdrive symptoms, sympathetic nervous system, heart palpitations, tachycardia, and low heart rate variability. But if you can see this as a single disorder, it makes sense out of everything. Instead of thinking that the patient has 6 or 7 or 8 different disorders, you see it under a unifying umbrella of pain amplification. And if you work on the pain, bringing down the pain amplification or drilling down to the causes, you can fix or improve everything on the list. So uncomplicated fibromyalgia or widespread hyperalgesia responds to these basic targeted interventions. They're very effective, and they're each important. You can't just address one. So achieving restorative sleep, kind of reducing that pain amplification, using medications usually that are effective for neuropathic pain, and sometimes musculoskeletal disorders, but more things like muscle relaxants than anti-inflammatories. There is a stress component, so helping people achieve their best state of mental health is important. And then the illness response to low impact exercise, strength training, and other things, as long as they're done within the confines of the illness and not causing too much pain amplification. And improved symptoms and function are the goal. This is really considered a chronic illness that you can't cure, especially not with a magic bullet. And symptoms can easily flare without ongoing behavioral and medical management. So it takes a teamwork of the patient gradually getting insight and becoming good at self-management, and their primary care provider or the provider who can assist them in these areas and remind them and sort of be a partner in managing these symptoms.
Dr. Bateman, I just wanted to add really quickly, with low impact exercise, there have been direct studies on water aerobics in amplified pain syndromes like fibromyalgia. And these are randomized control studies that show that it's as effective, if not more so, than many of the pharmacological therapies available. And I think the underpinnings of that idea are that when you are in water, you're reducing weight off of the joints, you're reducing resistance that you might otherwise have in a traditional gym setting. So you're not exacerbating the pain to a point where you make their symptoms so much worse that they can't proceed with that therapy. You're giving them something that they can actually participate in and move forward with.
Good, thank you. I appreciate that comment. And I'm going to mention that I'm kind of skimming over the details and the references for fibromyalgia because there's a big literature out there. And some of these things are just really considered common knowledge. We just need to reinforce them and make sure everyone understands that these very basic types of interventions are helpful. And it's important to have correct expectations about how much patients will improve with this chronic illness. But having that partnership and someone who believes them and supports them is most of what patients need. Just someone who will listen and help. So a comment about opioids, and this was known before everything about the opioid epidemic kind of flared, but opioids used daily for pain amplification syndromes become ineffective due to tolerance, and they can actually increase hyperalgesia over time. And what I found is it's really difficult for opioid dependent patients with pain amplifications and syndromes to reduce their doses or taper off opioids because they have a primary disorder of hyperalgesia and it becomes dramatically amplified by opioid withdrawal. So we should be very compassionate to our patients who are opioid dependent, who have these underlying disorders, because we're asking them not just to go through withdrawal, but to go through withdrawal that dramatically aggravates their underlying disease. But we generally, I have two patient populations, the ones that were put on opioids in the past that I'm holding steady or slowly going down on, and then patients I no longer treat any of these syndromes with chronic daily opioids. So I have my opioid naive patients and my opioid dependent patients. I'd like to spend a moment talking about a very interesting medication called LDN. And this is not an FDA approved drug for what we're discussing. It is FDA approved. Naltrexone hydrochloride is FDA approved for treatment of alcohol and opioid dependence. It comes in a 50 milligram pill, but there's a really very interesting broad interest in using low dose naltrexone, usually 1 to 5 milligrams. It needs to be compounded for all kinds of disorders related to neuroinflammation well, actually, I will just tell you that if you go to that website there, this is a very interesting worldwide website of people trying to pool data on their experience with low-dose naltrexone. It's very, very interesting, and you can see that it's been used, if you go to this site, for many, many diseases. But what I want to say is, and I've prescribed all the FDA-approved drugs for fibromyalgia a long time, and worked in pharmaceutical trials in the past. And I think LDN will never get an indication because there isn't a pharmaceutical company that will do, foot the bill for these phase 3 clinical trials of LDN. But I think LDN would stand head to head with any of the FDA approved drugs for fibromyalgia in terms of how reliable it is at reducing allodynian hyperalgesia in fibromyalgia patients. So just before I leave fibromyalgia, I just want to say that just reinforce what we talked about with small fiber neuropathy. So it's possible that 40 to 50% of adults and 90% of adolescents meeting fibromyalgia criteria have an underlying small fiber polyneuropathy. And I just want to, what really made the difference for me was really being able to visualize where these C fibers are, where these small nerve fibers are. They're sensory nerves and the postganglionic nerve fibers of the autonomic nervous system. These sensory nerves are in the skin, affect the heart and organs. No wonder people with this have bladder pain and bowel pain. And then efferent nerves to smooth muscle. And this is, sometimes we don't think about smooth muscle. We think about skeletal muscle, but smooth muscle is what opens and closes tubes and makes your bladder function and your bowel function. And it can change everything if the smooth muscle or the nerves to smooth muscle in your body are impaired. So what I'd like to say, and challenge people is, does knowing this change your perspective and approach for someone who meets criteria for fibromyalgia. And I just want to reinforce that the sensory symptoms, they're mean, and they're weird. And if you don't have an open mind to listen to someone and they're describing, you know, these strange sensory signals and transient electric shocks and things, you can think they're crazy, unless you can attribute it and understand where it's originating and what drives it, including things like changes in perfusion from orthostatic intolerance can drive these symptoms. And then the autonomic nervous system areas that are affected that Dr. Yeoman talked about really can be very disabling to patients. And I think it's a little more challenging to treat fibromyalgia when there's a small fiber neuropathy, and it's also maybe just not as responsive to treatment. So the point, the practical points I want to go away with is that people who have small fiber neuropathy have a normal physical exam and a normal neurologic exam a lot of the times, especially the way we do it. So kind of even a thorough neuro exam, if it doesn't carefully examine the sensory domains, can miss small fiber neuropathy, and they can be normal, even hard to pick up on a clinical exam. You send someone to a neurologist, you get an EMG and nerve conduction, it's just they're going to be normal. So that whole group of people who have this have been sort of dismissed as that it's all in their head, or they're whiny, or conversion disorder, or whatever. And Dr. Yeoman pointed out that abnormal skin biopsies are the way to make this diagnosis, and they're not perfect in terms of sensitivity and specificity. And it's hard, you know, there's kind of a spread of the expertise in labs at reading these biopsies. I don't always get a skin biopsy in my patient because there's a phenotype that presents that can be classic, and you can look at pain diagrams and the list of symptoms and basically assume there's a small fiber neuropathy even if you can't get a skin biopsy. And the point is to seek out and find any treatable or reversible causes of that underlying small fiber neuropathy, and there are many. And then you continue to do symptomatic supportive care and to treat the comorbid conditions that come from having a small fiber neuropathy. So I just want to again highlight with a case, and this is a real person who came to my clinic, and until I started doing more testing and understanding, I got kind of frustrated with her too. I mean, she was just constantly tired and couldn't function and wouldn't exercise, migraines and all kinds of pain, and she was always depressed and dizzy, and I just couldn't get her to do anything until I did orthostatic testing, which led to a skin biopsy, and she had small fiber polyneuropathy. And I just want you to take a look at her orthostatic testing. So I was so shocked, actually. So you can see her supine, blood pressure and heart rate just look normal. That would not get any attention in a doctor's office. But as soon as she stood up for the standing portion of the test, you can see that her blood pressure drops out and that her heart rate goes up dramatically. And so she meets criteria for systolic orthostatic hypotension, which is defined by a drop of greater than 20 millimeters of mercury, supine compared to standing. And she meets POTS criteria. It's more than just POTS, but she had an increased heart rate of 41. But not only that, she had symptoms. And if you could look and see that we recreated her sensory symptoms and her dizziness and her nausea and her feelings of electrical buzz in her body. And just again, to look here, pulse pressure was 56 lying down and dropped to 13 by 10 minutes in the test. And we've, through some of our research, started to use a little equation to understand, you know, how low is too low of the pulse pressure, because almost everybody gets a narrow pulse pressure when they do orthostatic testing. But there's an equation, the pulse pressure over the systolic blood pressure should be 25%. So it should not fall lower than that. In her case, it drops her pulse pressure over the systolic blood pressure is 14%. So no wonder she doesn't want to get out of bed and doesn't respond to treatment and can't exercise very well. And what's really, really important is she didn't know she had this until we did the orthostatic testing. So she was convinced that it was mostly mental health issues, but she just gave up. But she was primarily managed by her mental health providers valiantly, right? But they need a little help. So I want to move on to the concept of orthostatic intolerance and why knowing or looking for orthostatic intolerance can be really helpful. So just remember that orthostatic intolerance is simply the development of symptoms during upright posture that are relieved by reclining. It's a very important concept. It isn't a specific underlying defined syndrome. It is just that this happens, and you can measure it, and it's treatable. And it's really important to know that orthostatic intolerance can exist in someone who has low blood pressure, normal, or high blood pressure in the typical seated position. So you can't really judge and know if someone has orthostatic intolerance without asking them about it and without doing orthostatic testing. Orthostatic intolerance, it's just a broad area. It can be caused by drugs, acute, chronic, medical, and neurologic conditions. But a lot of chronic orthostatic intolerance, and you should think about those things if your patient has orthostatic intolerance, but a huge amount of chronic orthostatic intolerance is related to pathology of the small fibers and the autonomic nervous system. And there are many causes: chemotherapy, autoimmune attack, connective tissue disease like hypermobility, post-viral and post-infection syndromes they can lead to small fiber neuropathy, but also autoantibodies to receptors that can, adrenergic and muscarinic receptors in some studies. And of course, mast cell activation can also create orthostatic intolerance. So knowing someone has orthostatic intolerance opens the door to a much better differential diagnosis and an opportunity to provide better care. And I'm going to drive the point home that tilt table tests are just simply not available to everyone or standardized, and they're not always looking for the same thing. And brief orthostatic tests are inadequate. If you do it, you need to do it 10 minutes, which is why we're trying to push out the protocol of doing the 10-minute NASA lean. The other thing is you have to start from supine. A lot of people start from seated when they do orthostatic testing. You have the patient just stand up from the chair, and those are not the proper ways, and those will miss a lot of orthostatic intolerance. I also use a lot of tracking devices, wearables, so my patients can track their heart rate to monitor and become informed how their behavior impacts their heart rate, especially in people with POTS. And they can start to understand their own orthostatic intolerance and to evaluate the treatments that we do. I'm just going to say that there are defined syndromes of orthostatic intolerance that are evidence-based. So we've talked about some of them: orthostatic hypotension, POTS. They don't really talk much about neurally mediated hypotension, which basically is just becoming near syncopal or developing syncope at some time during the orthostatic testing. And the reason it's important is there's a really substantial evidence-based literature for POTS, orthostatic hypotension, and NMH. And the things we know from that literature can generally be applied to most orthostatic intolerance syndromes, as long as you know what the underpinnings are. So just some very basic advice about orthostatic intolerance. It can be worsened. These are simple things that can help people a lot by becoming overheated when you vasodilate, dehydrated when you become hypovolemic. Prolonged bed rest and deconditioning can really aggravate orthostatic intolerance, which is kind of a conundrum in some cases. Never miss medications, because it would be a shame to not realize that the medication your patient is taking is creating orthostatic intolerance. And of course, the most important behavior is prolonged standing or sitting without moving, sitting with your feet on the floor. And just simple changes in behavior can really improve symptoms of orthostatic intolerance. So the other basic categories of interventions for orthostatic intolerance: one is you increase intravascular volume, fluids, sodium. There's a medication called fluticasone that is like aldosterone that helps with sodium retention. And even the trick of rapid water ingestion just before 15 minutes before exercise can be very, very helpful in reducing the impact of orthostatic intolerance. Next category is external compression or internal constriction of blood vessels. So external compression, compression socks, pants, sleeves, whatever people can put up with. And as an example, the drug midodrine is a peripheral alpha-1 receptor agonist that is indicated, has an FDA indication for orthostatic hypotension. It basically is like chemical compression sleeves because of where these alpha receptors are located in the skin and also GI and genitourinary tract. And the alpha receptors are in the brain, but midodrine doesn't cross the blood-brain barrier, so it mostly works on peripheral alpha receptors. It has a short half-life, so it has to be dosed frequently, and the side effects are basically the side effects of this vasoconstrictive effect, goosebumps. In young people with orthostatic intolerance syndromes, you don't have to worry too much about overcompensating and making people hypertension. But as people reach middle age, and especially if they have comorbid conditions that put them at risk for hypertension, you need to be careful and screen to make sure that you don't make someone hypertensive while you're trying to improve their orthostatic intolerance.
Regarding the compression clothing, I wanted to add two little gems. The first is I've found that medical compression clothing can often be really difficult to put on, to wear. People don't want to wear it in the summer because it's too hot. And I found that there's a lot of really good athletic wear that functions as compression clothing now. So Under Armour, Nike, Lululemon, Athleta, those are good options for people. And then the other thing I would add is the degree of surface area that is covered really seems to, as you increase the surface area covered, the more you get a symptomatic response. So if you have compression only up to the knees, sure, you're keeping venous pooling from occurring, below the knees, but you're just putting it into your thighs. If you actually include the entirety of the legs and abdominal compression all together, you get the most profound responses.
And I work with the patient because some people just can't put up with it, and some people have too much pain and allodynia, too much pain in their legs to wear the socks. But I just try to get people to do as much as they can. And they say, well, how much compression? It's like, well, the more you compress, the better it works. The more area you compress and the more the compression. But I try not to get too black and white over it. The more important thing is that people can buy in. So if there's an abnormally rapid heart rate response to orthostatic stress, to this venous pooling, you can use low-dose beta blockers. We sometimes use clonidine. Now there are many indications for beta blockers. They're all a little different, but we tend to use them however we want in practice. Clonidine is labeled for hypertension, but it can be very effective at reducing that. It's a central alpha agonist, and especially in people with a lot of anxiety or insomnia due to its sedating effects. Just a quick word about pyridostigmine. This is a drug that we have used extensively in the last couple of years in our clinic. This is off-label use. This is Mestinon, if you remember, a drug for myasthenia gravis. But it raises acetylcholine, and that acetylcholine is the major neurotransmitter, not only at the neuromuscular junction, but most of the parasympathetic nervous system, and it's some postganglionic sympathetic synapses. It can be extremely effective at reducing that sympathetic parasympathetic imbalance and improving what is thought to be a left to right shunt at the tissue level. And there's a study going on right now, Dr. Systrom at Brigham and Women's Hospital, to try to understand, using invasive CPET testing, exactly what the mechanisms are and what pyridostigmine does. So also improving the muscle pump, so making sure your core body muscles are strong and your leg muscles are strong. That's a really important part when you're moving of helping venous blood return. And there are a few tips. I'm not going to spend too long. They'll be in the slide. They're kind of common sense, but tank up on fluids where compression when you're exercising. Do your compression lying down or semi-recumbent. And if you do go on a walk, don't stop, right? And pant. Come in, hydrate, put your feet up afterwards. And you got to be really patient at working up on some of the cardio. And as Dr. Yeoman said, exercise in water is good for so many things, not just pain in rheumatologic pain, but it's like being in a compression suit when you're in water, or you're horizontal, so orthostatic stress plays less of a role. Now, I want to introduce to you the clinical diagnostic criteria that were published in 2018 for what we're now calling ME/CFS, myalgic encephalomyelitis chronic fatigue syndrome. And I would just say, forget anything you've ever thought about chronic fatigue syndrome, which was the published criteria for chronic fatigue syndrome over the years were intended to be research criteria, and they were broad and non-specific and confusing. So really, this is an evidence-based report to say, is there a core disease that we consider to be ME, which is the term used outside of the US, and we kind of kept that term CFS in there so we wouldn't forget our origins. But this is a really amazing report, and I want to tell you about the proposed clinical diagnostic criteria then these are really to help people make a more timely diagnosis of a core disease that is incredibly debilitating. So in order to meet ME/CFS clinical diagnostic criteria, there are these core criteria that must be met, and they must be moderate to severe and present at least 50% of the time. You must apply frequency and severity criteria, and that's one reason we do that in our review of systems. So very easily we can look and see how serious these domains are. So number one is impaired function, and you notice fatigue was kind of pushed out into farther in the sentence. So impaired function, it can manifest, be interpreted as fatigue, but it's really a functional impairment of function. Second is post-exertional malaise. Third is unrefreshing sleep. And then either cognitive impairment or orthostatic intolerance syndromes. And you only have to have one of those. And then it's recognized that there are many other symptoms that can develop and manifestations, all kinds of pain, all kinds of immune, allergy, inflammation, and sensitivities, and this aura of symptoms of viral reactivation and other infection sequelae. But in the evidence-based report, they really weren't core, so, meaning that everybody didn't have all of those. So it was quite variable. So the core criteria, really the place to start, and then you have to realize that individuals can present with much more varied presentation. So let me tell you a little bit more about why diagnosing ME/CFS matters. So this is a clinical presentation phenotype that's well supported in the evidence base as a common debilitating core of symptoms that aren't otherwise explained by our usual diagnoses. And many of these people seem to have a post-infectious syndrome that has neurologic, metabolic, and immune and inflammatory sequelae. It will be more complicated than that as we sort through kind of subset phenotypes of this disease. But if we don't put them all together in the first place, it's really difficult to dig down and understand subtypes. And many of the conditions that Dr. Yeoman discussed yesterday are very common comorbid conditions in patients with ME/CFS, including or people with fibromyalgia or people, and FM can be secondary to ME/CFS. So we're trying to understand this overlap, but these are comorbidities that can be standalone diagnoses, but they can also occur in people who also meet ME/CFS criteria. And the more comorbidities they have, the more sick they are. So you remember we talked about using the SF-36 scores to try to interpret the severity of illness and what components come from physical versus mental health. And I put on the right side this graph that I showed you in the first lecture, whereas these are the norms. And remember that the physical are on this end and the mental health are on this end, and then they kind of merge in the middle. And so this is what we see in the normal population. Here are these other chronic illnesses, the typical scores across the 8 domains. And this just happens to be a small study from our clinic, but it matches most of the SF-36 data in ME/CFS. And I just want to show you, okay, here's our healthy controls right there, reproducing the healthy control normals. But I want you to see that the domains, the physical domains, are lower than any other chronic illness, at least in this study and many other chronic illnesses. So it's very important to make a diagnosis of people who, and you remember the cases, you know, that were flat along here. And in people who don't have comorbid mental health problems, they have relatively preserved mental health scores, as you can see just a little bit below the healthy controls over here. So this is role emotional and mental health. Vitality and how role physical almost always are the lowest points. As you can see, bodily pain is not always the primary problem in people with ME/CFS across the board. So I just want to go through these domains quickly and help you see some of the scientific underpinnings that support using these clinical diagnostic criteria. And we talked about this a little bit using questionnaires, hours of upright activity, and those things in the first lecture. But there's a very high quality literature now of quite a few studies to replicate this. First of all, do this lower one, that ME/CFS subjects are unable to replicate CPET testing 2 days in a row because the effort to do the test on day 1 reduces their ability to replicate their test on day 2. And this would be pretty unique in CPET testing across all other known illnesses, with maybe the exception of mitochondrial disorders. But even more exciting, up above, this is Dr. Systrom that I was telling is doing the pyridostigmine studies. He's been able to show in very sophisticated studies using invasive cardiopulmonary exercise testing that ME/CFS subjects have preload failure, inadequate ventricular filling, this venous pooling and reduced preload, and impaired oxygen extraction, in that they are unable to utilize the oxygen in the bloodstream effectively for a variety of reasons. Another set of studies that backs up impaired function is a number of studies in the field of metabolomics that are trying to use big data to show that there are altered metabolism, maybe at a cellular level, similar to maybe mitochondrial disorders or something in the production of ATP. So we know people have impaired function, and we know there are physiologic reasons underpinning it. We need to learn a lot more about it. So the next is called post-exertional malaise. And basically post-exertional malaise, or PEM, is what happens if you exceed your energy and try to keep pushing forward in spite of the fact that your cells have run out of ATP or whatever, or they're not perfusing, or you're not getting enough oxygen to the tissues that are doing the work. And it's very physiologic, it's multi-system, it's basically illness worsening from engaging in activity, and that can either be physical or cognitive. So the primary intervention for ME/CFS is actually not exercise, it's learning, it's energy management, activity management. And it has to apply to both orthostatic stress and physical activity and cognitive work, and emotions also they're a very big stimulus and stress on the brain that uses up more energy. So let me just show you this study that convinced me of this. This is way back. These are some colleagues at the University of Utah. Alan Light and his wife, Kathy Light, and other people in their lab. And I said to him, there is something weird going on in these patients with ME/CFS. They can't exercise without consequence. And he said, oh, we should be able to measure that. So we set up a study. This is back when there was a lot of studies using gene expression. That's basically measuring messenger RNA as it's produced from the DNA template. And in the top study, so these were our healthy controls, and we measured all of these levels of gene expression. So these are sensory receptors, these are adrenergic receptors, and the bottom are immune markers or cytokines. And we just drew the blood of people before they exercised. Then they exercised on a bike and just at a constant level for 20 minutes. It wasn't a max test or anything like that. And then blood was drawn 30 minutes, 8 hours, 24, and 48 hours after that single exercise stressor. And what was just shocking was the patients, the 20 patients I picked that I defined as having ME/CFS, back then we just called it chronic fatigue syndrome, had a dramatic response to exercise. So within 30 minutes of this same exercise stressor, they were having magnitudes of increases, fold increases in sensory, adrenergic, and immune markers. And these are on all separate blood draws, so they really can't be an anomaly. And this is a small set of carefully chosen patients that I knew clinically that had this cap on how much they could exercise. And what this taught me is, so often after this exercise challenge, patients don't feel the consequences for 24 or 48 hours. But if they go out and exercise again on day 2, they're going to create an advancing problem that's impacting the sensory, adrenergic, and immune system. There's a small control group with MS, fatigue, down below. And I think that purple is probably a spurious result at 24 hours, but who knows, it was just a small amount. But this really changed my attitude and helped me understand the difference between some chronic fatigue and pain illnesses and this one, where the primary intervention is to reduce the development of post-exertional malaise by changing your behaviors. And so pacing is limiting activity to the available cellular energy. It's short activities spread through the day. It's engaging in recovery behaviors between activities. It's avoidance of debt, we call, or the post-exertional malaise, and especially stacking it up. And really just being in a totally different mode than what patients are often told to do, which is to go exercise, do graded exercise, and to stop pouting about their fatigue and not be afraid to do things. So pacing reduces the frequency and severity of post-exertional malaise, and it improves symptoms and function. So I just tell people what they try to get a clue about what they can do and kind of set their life up that way. And the goal is to be in a steady state where a night of sleep puts you back to baseline and you're not stacking up the pathology of extra activity. So I'm just going to go quickly through the other core symptoms. I think we're more familiar with them. So unrefreshing sleep, this was from a big study comparing healthy controls response to this question in the orange, and patients with ME/CFS response to these questions. And this is based on, as I said, at least moderate severity and occurring at least half the time. And you can see almost all aspects of sleep, but you can see why unrefreshing sleep made it into the definition, because these things all result in unrefreshing sleep. There was a big study done of Dutch ME/CFS patients. This is in the IOM report. They excluded everybody, all the ME/CFS patients with primary sleep disorders, and analyzed their polysomnography. And they kind of fell into these four groups. People who slept too much and had too much REM, people who had less REM, people who had multiple arousals, and then people who just couldn't sleep and didn't have REM. These don't even mean, they're not even necessarily discrete groups. They may be phases people go through as their cyclic sleep is very abnormal. So to me, this is strong data that we need to help people with their sleep. And this is one of the things that we try to do. The aspect called cognitive impairment, this core symptom is one of the most overlooked, but maybe one of the most disabling symptom of ME/CFS. And there is enough evidence to suggest that patients have slowed information processing and some deficits in working memory and reduced attention. But if you have slowed information processing and deficits in working memory and problems with attention, it's very difficult to do anything that is expected to be efficient. So time-sensitive things, executive function, all the things that adults need to have in the workplace. And as I said, there's growing evidence of neuroinflammation in the brain. But let me show you this study that I love. It's done by a friend of mine, Dane Cook, who was really doing a study to look at functional MRI in a small study with 15 ME/CFS patients and 15 healthy controls. So these patients, he wanted to look at cognitive impairment, do functional MRI, and then to chart how people did. But this one kind of subpart really has always caught my attention. So the subjects were asked to take a fatiguing cognitive task test called the PASAT, the PACE Auditory Serial Addition Tasks. And they did it 3 times before exercise. So that black line on the chart is the point of exercise. And then they did this test 3 times after exercise. And if you look at the gray bars that are the controls, and these bars are the number of errors in the cognitive test. The gray bars go down each time. There's a learning effect. Each time they do the test, their number of errors goes down. And after they exercise, their number of errors goes down even more. Their brain's getting perfused. And by the time they're done, they're having almost no errors on the test. If you look at the ME/CFS patients, they start pretty even. But each time they take the cognitive test, they get more errors because cognitive work is causing them to have cognitive dysfunction. And then they also get more and more errors after they exercise when they have abnormal preload and abnormal oxygen extraction, as we know from these other studies. So this is a really amazing a demonstration of how cognitive impairment might be impacting people with ME/CFS. These may be the most limiting aspects of illness and a primary reason why people really are unable to sustain their employment or succeed in school. And if you don't measure it, when you're dealing with someone who has cognitive slowing and they can't focus and they have memory deficits, they're just annoying because they take longer to interview and they forget things and they don't follow through and they have to write everything down. But if you don't realize it's from a disease process, you miss an opportunity to really help them. And I also want to mention that these cognitive impairments they may be primary, but they're also aggravated by the cerebral perfusion deficits of orthostatic intolerance. So we don't understand all the reasons behind their cognitive impairment, but it's definitely there and a very important part of these core symptoms. And I'm not going to go into more support of orthostatic intolerance because we've been talking about it the whole time. I just want to say that supportive treatment for orthostatic intolerance in ME/CFS can improve function and symptoms, and it gives you a comorbidity to aim at. And again, these are other illness manifestations that are not core, but are common across the spectrum of people who meet these criteria. The pain can range from very little to incapacitating widespread pain. Almost all PEM is associated with an increase in pain and achiness and flu symptoms at a minimum, and it's really uncommon for people to not have headaches. There are a lot of non-specific immune manifestations we're still trying to understand that have to do with allergy, inflammation, sensitivities, and you can kind of throw mast cell activation in here, and some people have a little bit of immunodeficiency and other people seem to have upregulated processes of chronic inflammation, but we haven't been able to put our finger on it yet. And then again, trying to understand the role or the interface with post-viral syndromes and other kinds of post-infection syndromes. So if you use these evidence-based syndrome criteria, it gives you an opportunity to have a management plan, a structure, so you can see the big picture and then dive down into not only the comorbid conditions, but the major presenting symptoms of fatigue, of pain, of disturbed sleep, of cognitive impairment. And they're all overlapping and integrated. But from the practical standpoint, you just need to, this gives you an opportunity to do a lot more to help people with all of these conditions, but especially people who meet criteria for ME/CFS. So the lack of FDA-approved drugs or evidence-based treatment guidelines does not mean I can't take care of you. And many of these patients, they get the doctor give them a diagnosis and say, this is not treatable and I don't know what to do with you. And that's just absolutely not true. I just want to bring up the concept of palliative care in chronic illness. I think we often think of palliative care as being end-of-life care in people with terminal illnesses, but there's a big push to, and it's because we haven't been doing it. So there's this big push, especially doctors who are deciding to go into integrative medicine and other maybe a little bit different than what I would do as a classically trained internist, because they want to provide palliative care to chronically ill people. Palliative care is the science and practice of symptom management. And chronic conditions produce symptoms, and poorly managed symptoms contribute to disease exacerbations and more severe illness and hospitalization. So the use and implementation of palliative care in the person with multiple chronic conditions promotes an optimal quality of life, improves physical functioning, and reduces costly care. And I can tell you this is true in our patient population that we see at our clinic with chronic widespread pain and syndromes that contribute to chronic fatigue. You can give the patient, even if they have basically by definition an incurable disease, that's what chronic illness means, that you can't just fix it with antibiotics or fix it with surgery. You can give the patient tools and confidence and partner with them in chronic management and be a good listener and learn. And it's amazing. I mean, most of what I've learned from my patients and personal study through the years. And you can really improve quality of life outcomes for your patients. And this can focus on, treating comorbidities as we've discussed, but it's also okay to treat symptoms, but you need to do it intelligently, not just opioids for pain or Adderall for fatigue. You want to aim primarily at treating the cause of the symptoms, and we've discussed some of those, and keep the core underlying pathology and comorbid conditions in mind, and then just be careful not to create new problems by simply treating symptoms. Our goals are improving function as the illness permits and to reduce symptoms, both of which reduce or improve quality of life. And it's very important to have realistic expectations. I think some doctors or providers are a little hesitant because they think the patient wants them to fix them with a magic bullet, and they know they don't know how to do that. But I have discovered that patients just want to partner with someone to help them. And you just have to have realistic expectations on both sides of the provider and the patient. And that is pain reduction, maybe not eliminating pain, improve function, but maybe never the formal level of function. And then this is the one that's important, is treating or improving one aspect of illness is not going to cure the whole illness. It's just, you have to take it piece by piece and be happy with small steps forward. But if you keep taking those small steps forward and working on these issues, the patient can improve. So just wanted to say that we work at the Bateman Horne Center, which is a nonprofit clinic, research, and education center. And really our mission is to create equal access for all of the patients that have been sort of marginalized because of the way we've been practicing medicine. And I know that it's really just a matter of being able to have access to evidence-based scientific research and some help in knowing how to provide the compassionate medical care. Dr. Yeoman, do you want to make any quick comments?
I don't have anything specifically to add, but I did want to ask you if you see any overlap between what's going on right now with the international viral pandemic and how that might affect the prevalence of these illnesses moving forward and what we see in our clinics.
Yeah, I mean, this is a very, very interesting moment in time. And everybody who works in my field, the first thing that came to mind was not necessarily what will happen to these chronically ill patients if they get COVID-19. It's how many people who get COVID-19 are going to go on to develop these conditions, and particularly the most debilitating one, which is ME/CFS. Because these conditions, we know that many pathogens, especially viruses, and in several different classes, have the potential to leave people, maybe as much as 10% of people who have those infections will have lingering symptoms very similar to chronic fatigue and fibromyalgia at the 1-year mark. So we hope that we'll all be paying attention to what happens to people with this infection, SARS-CoV-2, whatever it is, CoV-2, and have the compassion to realize that they might not get over this illness, a significant portion of people, and they're going to need our attention and care.
If there aren't any questions, I thought I would just add very briefly, having been semi-recently trained both in internal medicine and rheumatology, I found myself seeing patients with these type of chronic pain and chronic fatigue illnesses, including ME/CFS, all the time. And the problem is I didn't know what it was. I hadn't been trained in medical school, in residency, or even in fellowship to recognize these illnesses. And all I could say was, well, this is not lupus, and so I'm not going to suppress your immune system as a treatment, but I never gave them answers. And so I just wanted to tie back into Dr. Bateman's message at the end. It doesn't always have to be about answers or about curative treatments, but just sitting and listening to the patient, delving into things with them and working on things one piece at a time is really a way to impact these people's lives.
Can I say just one more thing real quick? And that is, we always get the question, and as Michael Harris asked, can we take patients? And we can, but we can only see a fraction of the number of people who would be referred to us. So that's why we're doing this as a nonprofit, so that we can try to improve education, access to information, because we really need doctors everywhere to understand these basic, very common conditions. And more people will be diagnosed, then the research will move forward and we'll learn more.
If you look, you will definitely find this.
We're so appreciative of the 3 days we spent together, and have a nice Friday.
Thank you.